Good evening, and thank you for joining today's webinar, COVID-19 and the liver, SARS-CoV-2 diagnostic testing and vaccine development. My name is Mark Russo, and I'm pleased to be moderating today's webinar. Today's webinar is being recorded and will be made available on the AASLD website and in Liver Learning. This webinar is being brought to you by AASLD and its over 6,700 members. Our members are instrumental in creating exceptional educational content, such as this webinar tonight, and I invite you to join us. You can play a vital role in bringing liver disease and treatment to the forefront and take advantage of the many member benefits we offer. Please visit aasld.org to learn more about becoming a member. This is the agenda for tonight. The agenda includes some housekeeping items, the webinar contributors and presenting introductions. You'll see that I'll talk a little bit about background for diagnostic testing and vaccine development. Dr. Patel then will talk about diagnostics and COVID-19. Dr. Ernst will talk about COVID-19 and vaccines. And then we plan on having a lively panel discussion with Q&A at the end of the presentation. Please be reminded that the webinar Q&A, submit your questions in the Q&A box at the top or bottom of your screen. We will answer as many questions submitted to the Q&A box as time permits after the formal presentation. We will not be taking any verbal questions during today's webinar. Questions will be answered at the end of the presentation. This work could not be done without the clinical oversight subcommittee members, which are listed in this slide, and I'd like to recognize them and my colleagues for doing such hard work on projects such as this, and including the AASLD staff. So I will be the webinar moderator for tonight. I am the medical director of, my name is Mark Russo, and I am the medical director of liver transplantation, chief division of hepatology, and clinical professor of medicine at Carolinas Medical Center, Atrium Health in Charlotte, North Carolina. Dr. Gopi Patel from the Mount Sinai hospital epidemiologist, will then present on diagnostics. And then Dr. Joel Ernst, professor of medicine and chief of the division of experimental medicine, will present on vaccines from the University of California, San Francisco. Then we'll have a lively panel discussion, be joined by our panelists as well as our speakers, with Dr. Peter Chin Hung from University of California, San Francisco, Mercedes Martinez from New York Presbyterian, and Philippe Zamor from Carolinas Medical Center. So I'll start the presentation highlighting that there's now more than 3 million cases of COVID-19 disease in the United States, and unfortunately over 131,000 deaths. Highlighted on this map are the disparities in testing even within the United States. You can see the dark green highlighted mostly in the Northeast indicates where there's been high rates of testing per million residents, and there have been lower rates of testing in areas such as the Southeast, which are now continue to see a persistent increase of cases and surge. This slide highlights a schema of the SARS-CoV-2 virus. There are multiple areas that we could test for. We could test for RNA, proteins, or antibodies. RNA, we can test with various PCR-based tests. Viral proteins or antigen testing, and then, of course, antibody testing. And these are some of the methods that we use to test for viral PCR. We could use a nasal mid-turbinate test or swab, deep nasal swab test, or nasopharyngeal aspirate test. These tests tend to be uncomfortable, and a little bit more recently, the anterior nair specimen has been instituted. These take personnel and some discomfort to the patient to institute. The saliva and some home kit tests may be a little bit more practical to institute depending on their test performance. This is a cartoon of the structure of the SARS-CoV-2 virus. It shows the two major antigenic targets of SARS-CoV-2 virus against which antibodies are detected. And this is the spike glycoprotein and the nucleocapsid phosphoprotein. The S protein is essential for virus entry and is present on the viral surface, as shown here, joining with the ACE2 receptor on the host cell. The N protein is the most abundantly expressed immunodominant protein that interacts with the RNA. There are multiple forms of the S protein, the full length, S1 and S2, or the partial, the S1 domain, or the receptor binding domain, which is important because this is a target for vaccine development. N is more conserved across coronaviruses than S, and within S, the receptor binding domain is more conserved than S1 or the full length S. Antibodies that bind to the receptor binding domain of the spike protein that allow viral entry into the cell are speculated to be the most effective, which is of course why this is a target for vaccine development. In the press lately, there's been interest in mutations in this virus, and what I'm showing here is the proportion of samples with this amino acid substitution resulting in the S spike area of the SARS-CoV-2 virus. And it's thought that this D to G change or mutation, the D614G mutation, enables the SARS-CoV-2 virus to more efficiently enter the host cell. Although it may more efficiently enter the host cell, it's not well known and it's not thought that this makes the virus more pathogenic. And of course here, we're talking about vaccine development as sort of the holy grail. And there's more than 100 vaccine projects. We're going to hear a little bit about this later from Dr. Ernst. At least 8 vaccines are in clinical trials using various mechanisms of action, which we'll discuss, including this ChAdOx1 virus, which is a virus which is a weakened version of a common cold or adenovirus that causes infections, but that has been genetically changed so it is impossible for it to replicate in humans. And we'll hear about the various types of and mechanisms of vaccine development a little bit later on. And finally, there is a guidance document that's been published by the FDA. I think there might be some concern with this rapid development moving forward to ensure that there's safety and associated with vaccine development. And the FDA has then published recently this guidance document for the development of vaccines for industry. With that said, I will now turn over the discussion to Dr. Gopi Patel to discuss diagnostics and COVID-19.
Thank you, Dr. Russo. You can go to the next slide. I have no conflicts of interest. And I think all of us, at least here in the United States, and as you showed early on, can really say at the beginning of this outbreak, there was a failure to test. And really, we're at the point where we want to test everyone and test them repeatedly. So the early response was really hampered, and the first CDC issue tests had issues with negative controls. Through the FDA, EUA, or emergency use authorization, if you look on their website today, there's almost 200 diagnostic tests that have received an EUA designation. Next. So real-time reverse transcriptase PCR is considered the gold standard, and usually using a nasopharyngeal swab, as Dr. Russo had said, which is quite uncomfortable for patients and does require an exorbitant amount of PPE. Just to give you timing, the genetic sequence was published on January 10th, 2020. And these PCRs, repeat amplification processes, to be positive require 40 cycles until complementary DNA can be detected. SARS-CoV is an RNA virus. The EUA process is very different than the traditional processes used by the FDA to approve tests. The EUA process leads to this rapid approval in the setting of a public health emergency, but is permitted to use contrived specimens. That means specimens that could be spiked with known positives that are not naturally occurring specimens. So in practice, you can imagine infectious material can be missed. So there is an overestimation of sensitivity, and I think those of us who've been through the pandemic or have had large surges have had those events where we're like, are you sure this is a negative test? Next slide. Also, you're seeing across the United States, and I think some of us who experienced the outbreak early on really saw a lot of instability in supply chain, whether it's increased demand for viral transport media, swabs. So we definitely saw decreases in the availability of the nasopharyngeal swabs, and we are expecting to see decreased availability of both the nasal swabs and nasal turbinate swabs that Dr. Russo mentioned. We're also seeing tons of issues and allocation of reagents and cartridges for our high throughput platforms. The PPE that is required for testing is exorbitant, and really the emphasis is protecting healthcare workers from unnecessary exposures. So something like observed testing, where a patient can collect a sample themselves, is something that everybody is looking into to help preserve healthcare workers and PPE. We all have suffered from limited testing in overwhelmed healthcare systems and overwhelmed public health departments. Testing was initially prioritized, and in the states who are seeing surges now, is prioritized for those requiring hospitalization. And we all know now what we didn't know then early on, that we have really had an inability to stem silent transmission. And it's unclear with any of these tests if they accurately identify those with presymptomatic or asymptomatic disease. This is just our story in the Mount Sinai Health System. The first case in New York State was actually diagnosed at our hospital, Mount Sinai Hospital, on February 29th, 2020. What we didn't know in the background is there was community spread throughout New York, and that was recognized on March 2nd. And the first case in our health system was hospitalized on March 7th. We didn't have high throughput diagnostic testing available until March 17th. So prior to that were a lot of phone calls for approval to departments of health. In fact, New York State, the first day they were allowed to test in New York State was February 29th, 2020. So lots of delays to receiving results and a lot of uncertainty. You can see once we could test, the sharp uptick and the sharp rise in the number of infections, and our health system topped out during our plateau week at 2,000 cases within our 8 hospitals. Next slide. This is very rudimentary and probably represents the immune competent host more than an immunocompromised host. But just so you see, the nasopharyngeal swab PCR can probably detect a virus prior to symptom onset, but it's much more likely to detect it early in symptom onset. And I think we know a lot more of what those symptoms may be. Early on, we didn't know anosmia could be a symptom of COVID-19. The other thing that's really important is this red line. That's where we can actually detect viable virus or grow viable virus. And there's more and more data suggesting that you'll see a lot of repeated positive PCRs, but actually you're not able to culture viable virus. And this is really important about having patients move throughout their healthcare needs and have repeatedly positive PCRs. The other thing that was learned very quickly is BAL specimens or sputum PCRs may be helpful in those patients that are presenting late in disease. Very early on here in New York, we told patients who are mildly symptomatic, please don't come to healthcare. Number one, we don't have enough tests to test you, and we really want to prioritize PPE and healthcare to those that are sick, but many people presented quite late. If you look at the antibodies, and I'll let Dr. Ernst speak more about antibodies, you'll also note that there's a suggestion that once you are unable to grow viable virus or obtain viable virus, that you see an increase in IgG specifically, which is what we're looking for in terms of vaccines and possibly immunity, and definitely what we're looking for convalescent plasma. Next slide. So in terms of false negatives, what are the risks? Patients might not be appropriately isolated, so you're putting other patients and healthcare workers at risk. And really early on, without that positive result, it really prevented us from enrolling patients in clinical trials for things like convalescent plasma or for remdesivir. There is a role to repeat testing. Obviously, if you clinically think someone has COVID-19 and you know early infections and late infections can be missed with the nasopharyngeal PCR, and also the nasopharyngeal PCR is not an easy test to get a good sample, especially in a reluctant patient. It's really important to consider testing again. It is very clear that doing a BAL or an induced sputum to get a good specimen from the lower respiratory tract is not without risk. They're both aerosol-generating procedures, but really it should be considered if the clinical syndrome truly is consistent with COVID-19. Next slide. And that's really important because our pretest probability influences how we interpret the test. You can imagine when, at least at the Mount Sinai Hospital, where we had anywhere between 750 to 800 patients in-house during that plateau week, that we often tested patients multiple times because based on the prevalence in New York, the exposure history and the symptoms, we felt everybody had COVID. And if that pre-test probability is high, the test loses its value. If it's negative, you're not going to believe that it's negative and you're going to continue to test again. I think, though, it hampered our ability to treat or offer treatment to these patients. So people report the real world PCR sensitivity is considered to be about 70%. And on the next slide, I'll talk about even with antigen testing, it's probably lower. So that's why these efforts to decrease the pretest probability are very important. So masking, social distancing, and appropriate use of PPE. So in terms of antigen testing, this has been highlighted in the news quite a bit in this last week. As of July 9th, 2 tests have this emergency use authorization from the FDA. They're quick, inexpensive point of care tests. You don't need the fancy equipment. You don't need the training. And they detect fragments of protein. They're specific and not necessarily sensitive for SARS-CoV-2. There is a risk for a false negative, and your pre-test probability matters. So think about it as the rapid strep test that we have in our primary care offices or urgent care clinics. You still do a throat culture if you really think the patient has strep, and that's the gold standard. So you don't necessarily take that negative rapid test at face value. And the same idea is here with antigen testing. If you truly think someone has COVID, you should do the gold standard test. Next. And I think we're all struggling. How do we deal with asymptomatic patients? So there is now a consideration to think about asymptomatic testing when you have adequate testing capacity. When there's a high prevalence in the community, you may do admission testing or anytime someone comes to healthcare. This is currently defined as 10% or greater in the community. Major surgery plan where there's an aerosol-generating procedure, so any intubation of the respiratory tract is anticipated. In our immune-compromised hosts, and I think there's still a lot of data that we're missing in this patient population, those who are known contacts, so that's the exposure history of a laboratory confirmed case, and those individuals where there will be a lot of morbidity if you introduce or propagate SARS-CoV-2 in their environment. So congregate settings like SNFs, jails, and dorms. Just to show you our story again, so we added many, many platforms over time, and our goal is to be able to do as a health system 2,000 tests a day. We hit our peak this Monday, and Mondays seem to be the day we do the most tests, usually in anticipation of surgery and usually in the setting of trying to clear patients from isolation. So a lot of repeat testing, and we've been hovering around this 1%, 2% for some period of time, but we're using this along with other healthcare settings in the community of New York City, really to decide when we're going to see an uptick. And I think all of us are really concerned about the 4th of July weekend, not just here in the tri-state, but across the United States. So I think some of us struggle with this. I definitely do as an infection preventionist. Persistent or intermittent PCR positivity and the discontinuation of transmission-based precautions. When can you take someone off of isolation? And we all know there are probably limitations to the care these patients are giving, especially in the hospital or healthcare setting when they're on precautions for COVID-19. Many of us have moved from a test-based strategy where you would get 2 tests 24 hours apart that are negative and then discontinue the precautions on a patient to a symptom-based strategy based on some of the data I presented earlier that viable virus tends not to be isolated after day 9 in immune-competent patients. In terms of a test-based strategy, it is much more conservative but very resource intensive, and it's recommended for vulnerable individuals at high risk for morbidity or immunocompromised. It should be noted, have prolonged shedding. I do anticipate, and I did not scour all the preprint literature, but I do anticipate we'll know more about prolonged shedding of viable virus in immunocompromised hosts. We saw it with flu, and we've seen it with other respiratory viruses. So one of the things other individuals are using, if you're able to get this, is the cycle threshold. That's the number of times that the platform needs to cycle before you detect a positive complementary DNA. And lower cycle thresholds are seen in hospitalized patients. And there's evidence that the replication competent virus or viable virus is not isolated in culture at higher cycle thresholds. Most institutions use about 35. No correlation with the duration of symptoms or the length of illness. but maybe a correlation with severity of illness and prolonged viral shedding. So in some of these cases, especially that we weren't able to test individuals in March and April, and now they're coming back to care to have those urgent procedures or elective procedures that were delayed, that perhaps using the cycle threshold will help individuals not re-isolate and not delay further those procedures. Next slide. So repeat positive. So you have someone who is positive, they had that 2 negatives, and then all of a sudden you test them in anticipation for a procedure and they're positive again, or they have symptoms and you're concerned for reinfection. You can use some of those cycle thresholds to help make some determination, obviously in consultation with other individuals and possibly with your public health department. But in the Korean CDC literature, which I invite you all to look at based on the link below, I think this was really helpful. Mind you, it's mostly in immune competent individuals, but on average of 45 days after they were cleared from isolation, we all know the amount of testing and tracking that Korea has done, they found other individuals who would have a repeat positive from their initial symptom onset anywhere between 3 to as far out as 82 days, and 37% had symptoms which prompted the testing. They did massive contact tracings, and they found what they thought were 3 new cases from all of those. I think it was over 280 individuals, and they were unable to culture viable virus, and they had evidence of neutralizing antibodies. So the whole country made the decision that patients should not be re-isolated, and these extensive contact investigations, which were very resource intensive, could be suspended. Next slide. In terms of serologic testing, I think the jury is out about the role, and part of it is there's over 100 FDA, EUA serologic tests that have been approved, but we think we can all agree that perhaps these are helpful in identifying potential plasma donors. Confirmed patients may have had SARS-CoV-2 infection, especially in the setting of not being able to test them. It can also be helpful to support a clinical assessment in persons presenting late in illness, where you might not want to do that BAL or sputum induction, or with post-infectious syndromes like multisystem inflammatory syndrome in children. Serosurveillance, so many of you know in New York State, there's a lot of serosurveillance happening where they were able to say that healthcare workers actually had lower positive antibody rates than, let's say, our MTA or transit workers and the general community in New York City. And it's a tool to determine the immunologic response after vaccination. And I think we're trying to figure out if it's correlated with immunity and the durability of these serologic tests. There are multiple commercial assays out there, as I alluded to, the ELISA and the lateral flow assays. And really the goal with any antibody test is to minimize the false positive rate and have a high specificity. And as I alluded to, additional data is required prior to altering public health recommendations. And that's why we still need to continue to mask, social distance, and wear PPE appropriately. So in summary, there are limitations, and I probably brought up more questions than we answered here, but limitations in the current diagnostic environment, which is really measuring the test sensitivity in asymptomatic or presymptomatic individuals, is an urgent priority. False negative tests, especially with high pretest probability, is not uncommon, so we can't reliably rule out infection if you have really high pretest probability. And in terms of serologic testing, there is a risk for false positive results, especially in low prevalence settings, and an issue with potential cross-reactivity with other coronaviruses that are much more common. I guess in New York during that period of time, they weren't so common, and they're primarily qualitative. And again, the biggest issue is we have unclear clinical utility and the durability remains unknown. And I want to take the opportunity to thank all of you for being at the front line. You really have been fighting for our lives and have demonstrated great agility and great humanity throughout all of this.
Thank you, Dr. Patel, for that excellent presentation. We are going to now move on to COVID-19 vaccines with Dr. Ernst. I'll pass it on to you.
Okay, thank you, Dr. Russo. You can go on to the next slide. I have no relevant conflicts of interest. So I wanted to just start by making a few points about why COVID-19 vaccines are so important, so crucial. As you well know, SARS-CoV-2, the cause of COVID-19, is highly transmissible by the respiratory route, and the disease can be incapacitating and obviously deadly. It can be transmitted by asymptomatic or presymptomatic individuals. In other words, somebody can be walking around in the community transmitting without having any symptoms. And obviously people who are exposed to someone like that don't know they've been exposed. It is, I think, likely that in the absence of highly successful, efficacious vaccines, COVID-19 will become an endemic disease. In other words, we'll see it periodically in the community. And one reason for that is that community immunity, or so-called herd immunity, is not that likely to be achieved by infection alone. The estimates, given the average number of people infected by one case, or by one person with a case of COVID-19, the calculation is that at least 70% of the community would have to have protective immunity for there to be effective herd immunity. And obviously, we don't want to have 70% of our population undergo the misery and the hazards of becoming infected. And obviously, as we're witnessing and experiencing, the economic and the human impact of COVID-19 is enormous. Next slide. So what do we know, or what do we think we know about protective immunity to COVID-19? Some of this is really extrapolated from the earlier SARS-CoV-1, the cause of the SARS outbreak in the early aughts, and some of it from the more recent MERS. Both of those were respiratory transmitted coronavirus diseases. And so in the aggregate, there's knowledge that makes us conscious that protective immunity might actually only be transient after infection. In other words, we know from those experiences, and also from experience with the coronaviruses that cause fairly benign upper respiratory tract infections, that within a year of infection, the antibody levels, at least, including neutralizing antibodies, which we'll detail in the next slide, can wane possibly to the level of not being protective anymore. In other words, this is not like smallpox or measles, where if someone is infected, they have durable, lifelong protective immunity. We think that we know that neutralizing antibodies contribute to protection. It's logical, it's extrapolated from closely related infections. And I think most of the things that we know about protective immunity to viral infections, especially respiratory viral infections, would predict this. The ultimate acid test of this is still pending, but I think that we can trust that this is pretty likely to be true. However, as Dr. Patel indicated, the presence of antibodies doesn't necessarily guarantee protection. The available antibody assays that are used presently don't measure the quantity or the quality of the antibodies. And what I mean by the quality of antibodies, I'll explain in the next slide, but neutralizing antibodies are thought to be helpful. And as I've detailed on the last line here, some antibodies can actually be harmful. And the precedents for this phenomenon termed so-called antibody-dependent enhancement come from other viral infections. The classic one is dengue, in which partial immunity, represented by non-neutralizing or sub-neutralizing levels of antibodies, can actually facilitate entry of the virus into macrophages and dendritic cells, which are fantastic cytokine factories, and actually worsen the manifestations of the disease. There's a precedent in coronaviruses as well. There's a feline coronavirus that was studied probably about 20, maybe 25 years ago, where the phenomenon of antibody-dependent enhancement has been demonstrated, and actually it is the cause of pathology in that feline coronavirus disease. So I've made the point here that the right antibodies are needed, and that is true whether they are obtained by infection or by immunization. Next slide, please. So the good news, among other things, is that there are multiple efforts to develop COVID-19 vaccines. And I've detailed the various approaches here. The first is a real classic approach, and that is to make an inactivated virus. The procedure for that is to grow the virus in culture, chemically inactivate it, and then inject it. And the precedent for this is the original Salk polio vaccine, which is actually being used again now in the global polio virus eradication campaign. It's really the starting material for the seasonal flu vaccine that's injected. And so this is a a procedure with a long track record. And it's not always effective. For example, inactivated respiratory syncytial virus does not make an effective protective vaccine. The next approach that I've listed here is an attenuated virus, and that is essentially accomplished by modifying a virus either by targeted engineering approaches or by random attenuation through serial passage. And the goal is to obtain a virus that really is unable to fully replicate and grow to high levels, but maintains its immunogenicity. And so in the cartoon there, I've shown that sort of this fully colored SARS-CoV-2 virus kind of turns pale. And again, a classic example of this attenuated virus approach is with the Sabin polio vaccine, measles, mumps, rubella. All of those are attenuated viral vaccines. There are more recent efforts that I want to talk about next, partly because the two approaches that I've mentioned are only partially successful and sometimes have intolerable adverse effects. The next category is nucleic acid-based vaccines. The first one that has been around probably for maybe 2.5 decades, although not yet in clinical use, is to start with essentially plasmid DNA, inject it generally intramuscularly. Host cells then transcribe it into RNA. The RNA is translated into protein, and so the antigen is actually produced by host cells, and sort of represented by that red spike protein glob there on the right side. A much more recent variation of this is an RNA-based vaccine, and there are several different versions of this being developed for COVID-19 right now. That short circuits the DNA step and injects RNA. It has to be protected from degradation, but then once inside of cells, it can be translated. Sometimes there's a self-replicating version of this so that the RNA is actually amplified as well as then translated into protein antigen. And similarly, protein antigen is produced by host cells, and an immune response recognizes that as foreign and develops T cell and B cell responses to it. Neither of these, as I mentioned, is actually approved by the FDA. The DNA approach has a long track record, mostly in cancer vaccines. RNA is much more recent. And the RNA approach is attractive, I think, in certain ways. Some people are concerned with DNA viruses about the possibility of integration of the vaccine DNA or the vector DNA being integrated into the human genome in inopportune places and potentially causing tumors. And RNA vaccines would obviate that problem. The next category is a purified protein with adjuvant, and this is, again, another very classic, well-characterized approach. Examples of this include the hepatitis B vaccine, tetanus vaccine, where purified protein, either recombinant or naturally derived, is mixed with an adjuvant, which is usually a small molecule that enhances antigen presentation and boosts immune responses. And there are a number of efforts making purified protein, adjuvanted protein vaccines for SARS-CoV-2. A variation of this is the generation of so-called virus-like particles, where the only antigenic or the only viral component is the protein itself assembled in such a way that it's actually presented in a format that looks to the immune system very much like a whole virus. And this is so far only used for the very, very successful human papillomavirus vaccine. It's a bit expensive, it's time consuming, but it's so far been very, very effective at generating effective immune responses. And then the last category, and Dr. Russo alluded to this category, and that is a category of viral vectored vaccines. In other words, antigen of choice, and this, again, the red spike protein glob there, is spliced into the genome of a viral vector that can either replicate or not, can at least serve as a vector that carries the coding sequence for the antigen into host cells. And again, like the DNA and RNA approaches, the antigen is produced by the host cell and generates an immune response. These are also experimental, although there are quite a number of these that have been fairly well advanced in clinical trials and preclinical trials. Next slide. So the goals of vaccine development, number one, are to generate vaccines that are safe. Needless to say, when we vaccinate healthy people, we don't want to cause them harm. We don't want to cause them intolerable subjective effects. And certainly we don't want to cause long-lasting damage. The next goal of vaccine development is to generate neutralizing antibodies. Next click. And what I've drawn here is an immunoglobulin molecule representing an antibody to the SARS-CoV-2 spike glycoprotein, the red blobs there. And the idea is to generate neutralizing antibodies in high titer, click, that basically bind to the target on the virus, block its activity, and in this case, block the ability of the virus to bind to it, the ACE2 molecule on host cells, and enter. So for many reasons that I alluded to earlier, neutralizing antibodies are thought to be effective targets and goals of vaccine development. There is emerging evidence that T cells can also contribute to immune protection against SARS-CoV-2. And so while there's no specific effort to generate predominantly T cell generating, response generating vaccines, they are likely to be a component of several of the vaccine strategies. Another goal, ideally, is to block infection where the virus enters. In other words, to generate mucosal immunity so that the virus doesn't ever even enter a host cell and replicate and cause even mild symptoms, much less be shed and transmitted to others. Another goal is to generate long-lived immunological memory. I mentioned earlier that there's concern that infection generates only transient immunity in the case of COVID-19. We would really like to have vaccines that generate long-lived immunological memory, ideally with one dose of vaccine, so that the population's immunity doesn't wane quickly and give an opportunity for additional outbreaks. And finally, I think the ideal vaccine will generate immune responses that recognize viral targets that mutate to escape. This is obviously a problem with the seasonal influenza vaccines. It doesn't seem to be a big problem so far with the spike glycoprotein of SARS-CoV-2. And so I think there's a bit of encouraging news there. Next. So there is a lot of vaccine activity in progress, and I don't want to go into a lot of detail, just to mention that there are several dozen different groups in industry and academics, in startup companies, taking various approaches. Now, the DNA and RNA vaccine approaches are attractive in this context, even though there are no FDA-approved examples of them. The main example, the main advantages is that they can be produced in large quantities rapidly. And so there are quite a number of efforts to develop such vaccines. Viral vector vaccines are probably the next most common group. The ChAd-Ox, the chimpanzee adenovirus vaccine that Dr. Russo mentioned is an example of these, and there's been a lot of news about that vaccine effort generated from Oxford University. And then there are protein-based vaccines, protein subunit vaccines, as well as the virus-like particle vaccines that I mentioned earlier. The VLPs, the virus-like particles, are attractive, but they're a bit slow to produce and maybe kind of later developments in the process. Next. So what are the stages of vaccine development? The stage we're in right now is really discovery and development and production. The stage several candidates have begun is to determine, is the vaccine safe? And obviously, if a vaccine isn't safe, it's not going to go forward. And so the process originates with small studies of escalating doses in otherwise healthy volunteers, and essentially adverse effects recorded and dose, sort of maximum tolerated dose identified. And in the case of most of those studies, there are samples taken that ask this next question, and that is, does the vaccine stimulate immune responses in humans? Mice are extremely useful tools, but not every vaccine that generates an immune response in mice generates similar responses in humans. So really that is an important element and can't really be otherwise predicted. The next stage, once you know that you've got something that's safe and can be expected to generate immune responses, and those immune responses are ideally have mechanisms that should predict protective efficacy. The next question is, the next step is the determination of efficacy, and it is, does the vaccine protect humans from disease? There are two approaches to this. The most common approach is to essentially randomize a population. People receive vaccines, some people receive placebo, and you compare the incidence of infection and disease in the two groups. That can be expensive. It can require very large populations. It can be very time consuming. And so an alternative is so-called human challenge models. I'll talk about that a bit in a minute. The final step is to ask the question, does the vaccine protect humans in the real world? And that's termed vaccine effectiveness. Efficacy is fine, but it's in optimized, young, generally young, healthy individuals, often in relatively limited numbers. And so on a population-wide level, you've got people with comorbidities, you've got people of vast ranges of ages, and you really want to know, does a vaccine effective, not just efficacious? Next slide. So there are other essential vaccine considerations, especially right now in a pandemic. The vaccines that we need immediately absolutely need to be able to be produced large scale and very, very rapidly. We need billions of doses of SARS-CoV-2 vaccines. Similarly, they need to be economical. When we need hundreds of millions to billions of doses, we can't afford to pay hundreds of dollars per dose, and so they have to be economical. Furthermore, not so much a problem or a challenge in the United States or other developed countries, but vaccines ideally need to be stable so that they can be transported to remote areas and administered to people who, for example, live in places where there's not electricity or reliable refrigeration. Next. So why does it take so long to develop a new vaccine? Why do people keep kind of clamoring about, the fact that it takes so long? Will we have this by the end of the summer? Probably not. By the end of the year? Also probably not. It's really that the safety studies in humans require time, because you can't really hasten the development of complications. In other words, some of the minor and very high frequency complications very quickly, but some of the less common complications require larger studies and more time of observation in order to identify them. And needless to say, for many, many reasons that we can go into in the Q&A session if somebody is interested, we really need to make sure that vaccines that we deploy here are safe. Next slide. Now, what about an alternative? What about so-called human challenge or, human challenge infection model? So, as I mentioned earlier, vaccine protection, efficacy in particular, can be determined in large populations naturally exposed to infection. That's slow and expensive. A much more rapid approach, at least in most cases it's more rapid, is to study small populations of volunteers that are experimentally exposed to infection after vaccination or receipt of a control placebo, called a human challenge model. This is much more rapid, or can be, and is much less expensive because you don't need large numbers of subjects. Now, the challenge here, not the infectious challenge rather, but the professional challenge, is that there are very substantial ethical concerns for performing human challenge infections when a reliable curative treatment is not available. And as you're painfully aware, we don't have effective treatment, much less curative treatment, for SARS-CoV-2. Human challenge models have been invaluable in development of malaria vaccines, for example, because if a volunteer who's been vaccinated is exposed to malaria parasites and then develops a fever, they're treated immediately, and the challenge strain is known to be drug susceptible. We just don't have that advantage for SARS-CoV-2. So right now there are a lot of discussions. Various committees, various professional bodies, various constituencies are very heavily involved in discussions of the sort of risk versus benefit of doing human challenges after various experimental vaccines in the absence of good treatment. Next slide. That's all. I thank you for your attention. Be happy to take any questions that come up.
Thank you, Dr. Ernst. That was really terrific. It really reminds us of why we wanted to learn about the mechanisms of vaccine development, the time it takes, and the labor of love it must be to develop these types of vaccines in order to help prevent disease. So now I'm going to invite our panelists to turn on their cameras, and we're going to have a panel discussion. I'll remind you, we'll have Dr. Patel and Ernst, and we'll also be joined by Dr. Peter-Chan Hong, Mercedes Martinez, and Dr. Philippe Zamor. And please enter your questions in the Q&A chat slide. Dr. Martinez, I'd like to start the first question with you. So most of the time when we're thinking about testing for SARS-CoV-2, we think about adults, but we see a lot of young people out there who are really adolescents in their 20s that we worry can bring home the disease to their grandparents. But what about bringing home their disease to their younger brothers or sisters or cousins? Tell us how you've approached this when you've seen a young child who may have been exposed or had the disease, and what type of testing you've implemented.
Thank you very much, and thank you everyone for joining this very informative webinar. Then in New York City has been many children with SARS-CoV-2. If the patient is symptomatic, we usually do the PCR, and that was the test that was available for a few months. I remember my first case was a baby, an infant 6-month-old that just have received a living donor transplant from the mom. And the mother tests positive 4 days after donating to the baby. They are both still in the hospital when we heard that the mother is positive. Then, it's a 6-month-old baby that got a liver transplant 4 days ago. They are breathing fast. They have a big belly. We don't know what is going on. And we test this baby. And actually, she was positive. She has a PCR positive. And her story became really long. Actually, we published this case report in Pediatric Transplantation. She developed a significant hepatitis 4 or 5 days after knowing that she was positive. We didn't know if this rejection is this hepatitis. She underwent a liver biopsy, and guess what? The liver biopsy report rejection and hepatitis. And they did an immunohistochemistry for SARS-CoV-2, and the SARS-CoV-2 immunohistochemistry was positive. We played with her immunosuppression. To make the story short, she got 3 liver biopsies in 4 or 5 weeks. And finally, she did okay. And she recovered, and minimum respiratory symptoms. We put her on CPAP for a few hours, but I think that we're more stressed out than she was. Really, everybody was nervous. This was our first patient post-transplant fresh with SARS-CoV-2. On the other hand, we have many other patients that report that the family member has been positive and they have almost no symptoms. And another memorable case was a patient that is a heart transplant patient that came admitted to the hospital with anemia. This patient has a very strong epidemiological history of exposure. One of the elderly family member has passed because of SARS-CoV-2. The younger sister was admitted in the hospital ICU because of SARS-CoV-2. And all this exposure has been going on for 4 or 5 weeks. Her SARS-CoV-2 PCR has been negative. And she got admitted, and she has anemia, hemoglobin of 5 without any clear losses. And she gets a liver test check, and the liver tests are in the 200-300. We keep checking, and it went up to 1,000 almost. And at that time, we did a liver biopsy on her. Very mild hepatitis. The liver is very quiet despite having very elevated liver tests. And the SARS-CoV-2 immunohistochemistry was negative. Surprisingly, the same day that we did the liver biopsy, we were able to check her antibodies. And then her antibodies for SARS-CoV-2 are positive. Then are we looking here at 2 different maybe pathogenesis of hepatitis in this patient? One that maybe has been virus-induced early post-transplant with positive PCR. And the second one that might be immune response, because she didn't have the SARS PCR positive, but she was positive for antibody. Then it's very interesting to see how in the pediatric population, when they don't have a lot of respiratory symptoms, but still they can have a lot of morbidity of other systems. Gastrointestinal symptoms are a frequent presentation, abdominal pain, diarrhea. Then we really think that many people think that this is not relevant for pediatric, but it's very relevant. A lot of kids get very sick without even start talking about the multisystemic inflammatory syndrome in children. That might be another topic for discussion. Those children get very sick, and they really should be careful because people get sick, adults die. There is not a lot of mortality in pediatric, but it could be a lot of morbidity, mainly when patients are immunosuppressed.
Thank you so much. I mean, that was very interesting and and I would like to now segue to Dr. Zamor about his experience in the adult population, particularly when Dr. Patel was talking about prolonged testing positive via PCR in the transplant population. What has your experience been, Dr. Zamor, with liver transplant recipients who are infected and maybe have test prolonged positive for SARS-CoV-2? Over time? How frequently have you tested them, and what has been the guidance? I think you have to unmute. Yeah.
I think certainly our experience here in the Southeast pales in comparison with our New York colleagues. That may change in the next couple of weeks to months, but we know from the literature that patients that are immunocompromised, both from the cancer literature and the transplant literature, these reports we're seeing out of Europe and Asia, that patients do tend to have a prolonged shedding of virus. Whether or not, like Dr. Patel said, virus is active or not remains to be seen. Personally, I had a patient of mine that was a patient, an SLK recipient, that continued to have prolonged shedding of virus, meaning she tested positive on PCR for, I believe, close to 2 months out from exposure. And the first thing we did, back then, because it was early on, is we reduced her immunosuppression. Primarily, we reduced her MMF. We kept her her prednisone dose and her tacro dose stable, but she continued to shed virus, I think, longer than the average patients do than we've seen in our hospital. I talked to our hospital epidemiologist colleagues, and they said typically that she continued to shed virus for, again, 2.5 months after sort of after symptoms first started. The issue with her is that she was actually she's a nurse, and she wanted to go back to work. And unfortunately, she worked at a nursing home, not really doing patient bedside care, but more in the administrative offices. So she kept getting tests, not because clinically we needed it or it was gonna affect our management or change our management, but she wanted to go back to work. And she obviously could not go back to work despite feeling fine, asymptomatic, having gotten over her acute illness, was actually never even hospitalized for her disease. So I think our experience with her and a few other patients that we've had mirrors that we've seen in the literature, again, from the different experiences out there.
Thank you. Segueing off that, this is for Dr. Chin Hong. Here we have a patient that he's presenting that very important that we know that the patient is negative. What is sort of the false negative rate with these PCR tests? Is there a better platform or commercially available assay with better test performance that you would have recommended in somebody like this who's going to expose individuals at high risk?
Yeah, so in terms of test characteristics of the PCR test with SARS-CoV-2, it's really depends on when you are sampling in the arc of disease. So of course, the virus incubates for about 4 to 7 days. So if you test too early, you're going to have a false negative in that sense. And it depends on operator characteristics too, by how much you swab. You can also increase sensitivity by combining specimens. And that was in that JAMA paper earlier on, but that was really maybe a different population from the general population of hospitalized ICU patients with pneumonia, where you combine, if you do the BAL plus the oropharyngeal plus the nasopharyngeal, you can increase sensitivity. I would say, it's when you look at it for official guidance, people just say, if you suspect disease, you swab again. If you have a negative, depending on further, further along in the disease process and symptoms, etc. But in a lab setting, when you're validating a test, when you look at statistics, they're like above 95% sensitivity, but you're comparing it to known positive tests. But in real world, I would say if you have to pin me down for a number with influenza, it's very similar. Like a real world setting, it's like in the 75% range. And of course, there's a whole issue, which we can get to, and whether or not a positive test means live virus. And we don't typically culture viruses, as everyone knows in this call, because it requires, higher BSL lab capability than the regular micro lab. So, we can go into the nuances of, what that might be. Basically, the bottom line is that thing that we're detecting real live virus or just RNA fragments, if you're thinking of them going out in the community and interacting with others?
Yeah, thank you. This brings up another issue that Dr. Martinez had raised, and I want to go to Dr. Patel now, and you can weigh in as well, Dr. Chin-Hong, about we see that children may have more of the gastrointestinal manifestations of COVID-19. So, Dr. Patel, has there been any role for testing fecal matter for PCR via PCR for the SARS-CoV-2?
So for any of these high throughput platforms, you have to validate the specimen type. And I think this is the issue with the EUA, as Dr. Chin-Hong sort of alluded to. It's not using traditional specimens. So you can use contrived specimens where you spike it with known positives. And I think that's one of the issues we're having with an overestimation of sensitivity. It doesn't reflect what we do in the real world. So there's definitely data out there that you can detect RNA in stool. The issues still occur about whether or not it's viable virus or shedding of RNA because of how tracts are connected in the stool. So I think in the peer-reviewed literature, I can probably count on both hands the number of times they were able to successfully isolate viable virus in BSL-3 labs from stool or urine. But again, I think the jury is still out about where in that sort of arc that Dr. Chin-Hong talked about, that's where you're worried about it being infectious. I think in kids, they're even though we have downplayed a contact part, kids are really difficult. It's hard to get them to wash their hands, although I think this generation of children will be much better. It's hard for them not to touch everything. And then in that case, they're starting to auto-inoculate their nose and their mouth.
Yeah, Dr. Martinez, do you have any further comments on this, or are there any homegrown tests that you're using at your institution for kids with testing stool samples?
Then actually we are trying to develop some kind of tests, and we are collecting stool samples in many children, and we are trying to test the immunocompromised patients and the ones that are not immunocompromised, but we haven't validated the test yet, but we are working on that validation of one of those tests.
Awesome. Now Dr. Ernst, we're going to move on to, there's a lot of questions about vaccines. This is from one of the attendees. And the question is, it's suggested that immunity to COVID may be based on T cells or other parts of the immunologic response other than IgG antibodies. If this is the case, how does serologic assessment of the antibody, i.e. B cell response, give us an idea as to whether an individual may be immune to COVID after exposure?
So I think that's a very valid question. I can answer it, I think, several ways. One, it may be, and I'm hypothesizing here, it may be that serologic testing and serologic results, presence of high affinity, high titer antibodies is sort of a surrogate for a T cell response. I think that in retrospect, this occurs fairly frequently with viral infections as well as certain viral vaccines. There's every reason to think that CD8 cytolytic T cells are probably useful against viral, killing virus-infected cells. There's not a lot of experience in making successful T cell vaccines. And so I think from the standpoint of rapid deployment or development and deployment, people are sort of anticipating that neutralizing antibodies may be sufficient. We'll learn whether or not that's the case. It may very well be that different vectors will generate different efficacies in terms of T cell responses, including cytolytic CD8 T cells, as well as CD4 helper responses that actually contribute to the high quality of antibody responses.
Let me follow up with that and ask you, you've disappointed a lot of parents out there about not having the vaccine time to go back to school. So a couple of multi-part question. I'll have to punish you for that. A multi-part question with a multi-part question. So the multi-part question is, when do you think a vaccine will be developed, and which antigen will be most immunogenic, and which of these techniques that you mentioned looks the most promising?
So I'm going to not answer the last question first. I think that the jury's out. We're going to find out what approach is most successful. And again, success here is a balance of ability to protect, number of doses required, the rapidity that it can be developed and produced in the large quantities available, and the economy. In terms of how soon are we going to have vaccines developed, we have vaccines developed, a lot of them. How soon are we going to start efficacy trials? Probably in the next few weeks. That part is actually being accelerated. The other thing that is being done, and I think it's good to see that the funding is available to do this, because there's an untraditional approach, and that is there are several organizations that have lead candidate vaccines that are already being funded to produce large quantities of their vaccine with the anticipation that they will be efficacious and hopefully effective. And so that part will be foreshortened some. I mean, if this were a purely industry-driven endeavor and this were not an acute worldwide pandemic, the standard would be to say, do the phase 2, do the phase 3, go to the FDA, get permission, then invest in a production facility, and then go up and start producing the vaccine. And that obviously takes a massive amount of time. So the financial risk is being absorbed by other sources of funds. And so there's actually vaccine production going on already, or at least in preparation for gearing up. But I think, again, we won't know soon how safe a given vaccine is. I think that we're going to get some additional signals. We may find one or more that flunks because of a safety signal that occurs early. But I think the safety concern, both on the part of investigators and regulatory agencies and on the part of the public, is going to take, I would say, at least another 9 months. I mean, I think before next spring would be rather surprising. I always like pleasant surprises, but I think we're not looking at a deployable vaccine in a population of people. Be fan.
Well, I would like to, we're just past the top of the hour. I'd really like to thank the speakers and the panelists for their presentations and for their insights into these questions. I will remind the audience that there are a number of webinars about every 2 weeks or so that are available at the AASLD.org website. They're recorded as well. And if you have further questions, please feel free to use the Engage platform. Thank you so much for your attention, and have a good night.